Hello. Today I'm going to talk about an approach to a wrist exam. My name is Jeffrey Chan, and I am a second-year medical student at McMaster University. I made this video with Dr. Janine Roller, a plastic surgeon trained at the University of British Columbia. We'll go over the anatomy of the wrist, including the carpal bones and supporting ligaments, important features on history, an organized approach to physical examination of the wrist, special tests, and a differential diagnoses of wrist pain. The wrist is formed where the radius and the ulna meet the carpus. It is a complex joint that is made of multiple joints. The carpus is formed from 8 carpal bones, which can be grouped into proximal and distal rows. Starting with the proximal row, the scaphoid is a boat-shaped bone which is 80% covered with articular cartilage. It is the most commonly fractured carpal bone. The lunate is a moon-shaped bone. The triquetrum is pyramid-shaped and is dorsal to the pisiform, which is a sesamoid bone. In the distal row, the trapezium is a saddle-shaped bone which articulates with the first metacarpal and is a common source of osteoarthritis. The trapezoid articulates with the second metacarpal. The capitate is the largest carpal bone and is the keystone to the carpal arch. The hamate has a volar-oriented hook which can fracture and injure the ulnar artery. The wrist is supported by extrinsic and intrinsic ligaments. Extrinsic wrist ligaments connect the carpal bones to the radius or metacarpals, where intrinsic wrist ligaments originate and insert on carpal bones. First, we will review the extrinsic ligaments on both the volar and dorsal aspects, and then review the intrinsic ligaments. On the volar aspect, the radioscaphocapitate ligament initiates at the radius and attaches to the scaphoid and capitate body. It forms a fulcrum around which the scaphoid rotates, helping to stabilize the proximal pole. The ulnocapitate ligament connects the ulna and the capitate. Together, the radioscaphocapitate and ulnocapitate ligaments form the distal border of the space of Poirier. The space of Poirier is a weak spot devoid of stabilizing ligaments, where the lunate can sublux or dislocate, resulting in perilunate injury. Another important ligament is the short radial lunate, which is a stout and vertical ligament. An important extrinsic dorsal ligament to mention is the dorsal radiocarpal ligament, also known as DRC. It originates on the dorsal margin of the distal radius and extends ulnarly, obliquely, and distally to insert onto the lunate triquetral interosseous ligament, and dorsal tubercle of the triquetrum. The intrinsic wrist ligaments originate and insert on carpal bones. They can be subdivided into ligaments that span the carpal bones within the same row, such as the scapholunate dorsal ligament, or span mid-carpal joints connecting carpal bones between the proximal and distal rows, such as the dorsal intercarpal ligament. The scapholunate ligament is composed of both volar and thicker dorsal components and acts as a primary stabilizer of the scapholunate joint. Injury to this ligament results in a dorsal and radial-sided wrist pain and can be associated with wrist instability and weakness. Disruption of this ligament can further result in carpal malalignment and altered wrist biomechanics. The dorsal intercarpal ligament, also known as DIC, extends from the dorsal tubercle of the triquetrum to the dorsal groove of the scaphoid. It also has attachments to the lunate, and in 50% of individuals, the trapezium. Its function is to provide stability to the carpal bones, in particular contributing to scapholunate stability. Together, the DIC and the extrinsic DRC, as mentioned on the previous slide, form a lateral V configuration that allows for normal carpal kinematics while stabilizing the carpus dorsally. The distal radio-ulnar joint, also known as DRUJ, is a diathrodial synovial joint that provides a distal link between the sigmoid notch of the radius and the head of the ulna. It allows the radius to rotate around the fixed unit of the ulna during pronation and supination. The DRUJ is stabilized by bony articulations and soft tissue structures. The soft tissue structures contribute to 80% of the DRUJ stability and can be categorized as static and dynamic stabilizers. The main static stabilizers include the triangular fibrocartilage complex, also known as TFCC, which we will review on the next slide, the radio-ulnar ligaments dorsally and volarly, the ulnar collateral ligaments, the joint capsule, and the interosseous membrane. Dynamic stabilizers include the extensor carpi ulnaris, also known as ECU, and the pronator quadratus. DRUJ instability can occur after a trauma or arthritis and several other causes. If the injury is not recognized and instability is not addressed appropriately, it can alter the kinematics of the wrist and forearm, producing pain, weakness, and potentially degenerative osteoarthritis. As mentioned, the triangular fibrocartilage complex, or TFCC, is the main static soft tissue stabilizer of the DRUJ. It is composed of soft tissue structures that span and support the DRUJ, as well as the ulnar carpal joints. It also suspends the ulnar wrist from the radius and transmits and absorbs compressive forces across the ulnar aspect of the wrist. It transmits approximately 20% of load across the wrist in a neutral position. The TFCC is made up of 6 components: the articular disc, also known as the triangular fibrocartilage, or TFC, of which the central 80% is avascular and has poor healing potential when injured. The dorsal and volar radio-ulnar ligaments are the primary stabilizers. Other components include the ulnar carpal ligaments, the meniscal homologue, the ulnar collateral ligament, and the ECU sheath, which is a secondary stabilizer. Evaluating a patient with a wrist complaint requires a detailed history and physical examination. First, review the patient's demographics, including their age, occupation, and dominant hand. Review the patient's chief complaint, followed by their history of presenting illness. If the injury is a result of a trauma, make sure to note when and how the injury happened, noting if this is a workplace injury. You also want to know if the hand and wrist have any prior injuries, and what investigations, treatments, or therapy have already been administered. If the injury is not a result of a trauma, review other etiologies for wrist pathology. Using the Vindicate approach, ask the patient about vascular, infectious, inflammatory, congenital, or autoimmune causes. The anatomical area of the complaint, radial, ulnar side, or dorsal-central, can be helpful to narrow the differential diagnosis and focus the examination. To identify the etiology, it is important to consider all the anatomical structures, including bones and joints, ligaments, tendons, and nerves. Here we show a non-exhaustive list of differential diagnoses based on location of the complaint. For radial-sided wrist pain, consider neuropathies such as carpal tunnel syndrome, tendinitis, ligamentous pathology, fractures, and arthritis. Ulnar-sided wrist pain can be due to neuropathies, vascular anomalies, tendinitis, ligamentous pathology including TFCC injuries, fractures, arthritis, and DRUJ instability. For a general physical exam of the wrist, start with inspection. SEES is a helpful acronym. For the hand and wrist, look for skin changes such as discoloration, masses, lacerations, and wounds. Also assess for edema, erythema, atrophy, asymmetries, and deformities. It is also important to note the resting posture and finger cadence. Next, assess the vascular status, including the radial and ulnar pulses, skin temperature bilaterally, and capillary refill. An Allen's test can be performed to assess for an intact carpal arch. Then, palpate for tenderness to localize the pathology. Then test for sensation in the medial, ulnar, and radial nerve distributions, as well as the median and radial digital nerve sensation. Then assess the patient's passive and active range of motion of the wrist, including flexion, extension, radial and ulnar deviation, and pronation and supination. Then assess the movement strength using the muscle power assessment, or MRC scale, as shown here. It is important to examine the joints above and below the wrist, as well as to compare the exam findings bilaterally for a complete physical exam. Certain physical exam maneuvers can be used to clinically evaluate and confirm a DRUJ injury. Patients will often report tenderness on palpation of the ulnar depression between the distal ulna and carpus. The compression test is done when the examiner compresses the radial and ulnar heads together and then rotates the forearm. pain with the maneuver, such as DRUJ instability, acute intra-articular injury, or arthritis. DRUJ instability is considered when there is increased ulnar translation relative to the radius compared to the contralateral wrist. It can be seen when the ulnar is more prominent dorsally and appears to sublux volarly with increasing pressure, creating a dorsal depression. 3 tests are often used to evaluate DRUJ instability. The piano key test is positive when the ulna head is depressed volarly with the examiner's thumb, and it springs back like a piano key when the examiner releases it, suggesting instability. The tabletop test is done by asking the patient to press both hands on a flat table with forearm in pronation. Finally, the grind test is done by compressing the distal ulna and radius with the examiner's hand and producing a grinding motion, which elicits pain to suggest presence of an arthrosis. Depending on our history and initial findings, we can narrow down our differential diagnoses with special tests. For radial side wrist pain, we can first assess for osteoarthritis of the thumb. Carpal metacarpal or CMC arthritis can be assessed by a grind test, which involves applying axial compression and circumduction. The lever test is performed by grasping the first metacarpal distal to the CMC joint and shucking back and forth in radial and ulnar directions. For the metacarpophalangeal extension test, the patient attempts to extend the thumb while the examiner provides resistance on the proximal phalanx. A positive result will be pain at the CMC joint. Certain signs, such as MCP fixed hyperextension, also known as zigzag deformity, may also suggest advanced stage thumb arthritis. For ulnar-sided wrist pain, we should always first rule out DRUJ injuries with the physical exam maneuvers mentioned previously. Ulnar impaction is another common cause of ulnar-sided wrist pain. The ulnocarpal stress maneuver can reproduce this pain. It involves ulnarly deviating the wrist and placing an axial load across the wrist while passively pronating and supinating the forearm. The pisotriquetral grind test is useful in examining the pisotriquetral joint. The examiner moves the pisiform in an ulnar and radial direction along with compression of the pisiform. Elicited pain may indicate pisotriquetral arthritis. In the Kleinman shear test, the lunotriquetral ligament is evaluated. The examiner applies dorsal translation to the pisiform with their thumb and volar translation to the lunate with the index finger to reproduce pain. Today, we went over the anatomy of the wrist, including the carpal bones, the supporting extrinsic and intrinsic ligaments, the distal radial ulnar joint, and its supporting triangular fibrocartilage complex. We discussed the important features and history and clues we can pick up from the chief complaint and history of presenting illness that can help us narrow down differential diagnoses. Based on certain suspicions, we can employ a specific approach to physical examinations along with special tests that can be used to localize pathologies of the wrist. Thank you for listening.